highlights from the Infection Prevention Conference, which has just finished in Birmingham. Ran over the last 3 days from Monday to Wednesday this week. We've got a great panel and some special guests. So John and I, as usual. And then we've got Dr. Jude Robinson, who is the new IPS President, and also Dr. Mark Garvey. So each of us are going to go through some of our highlights from the conference, and then we're going to have a bit of discussion following each person's take on the conference and themes and what they enjoyed and what they found interesting. And we encourage you guys to ask questions as well. There's a Q&A box at the top of your screens, or perhaps on the bar, depending on which display you're using. So please use the Q&A for any questions that you might have about the conference or about each presenter's themes. The meeting is being recorded and will be made public afterwards on the IPC Partners YouTube channel, just to make everybody aware of that. So without further ado, we're going to start with Jude. So Jude, over to you.
Yeah, thank you. So yeah, it was really difficult to pick which sessions I was going to do highlights on. So I've picked a couple, and if I've got time, I might talk about another one. So the first one that I really wanted to talk about was Dr. Sam Machin. She is an Associate Director of Patient Safety at the University Hospital of Sussex, and she did a real pragmatic session around the concepts of PSERF. So she made a really compelling argument about moving to systems thinking and really digging deeper, and not just the single case or the single incident. And she talks about focusing on work as done and not the work as imagined. Now, I'd not heard of this expression before. So what she does is she describes work as imagined is your guidelines, and what are your processes, your policies. And what she suggested is that they should be like fluid. We shouldn't have sort of static work as imagined. And then she describes work as done. This is actually what happens in real life. And what she recognises is that there is always a variation, and what we need to do and what we need to be asking is actually, why was there a variation? And that moves the focus onto the reasons for the deviations rather than just the deviation itself. And she highlighted a really good system-based tool for investigations that can be super, super helpful. So I really found her session really, really helpful. I'm now going to discuss Tracy Cooper's lecture. So those of you that know Tracy, she's an absolute phenomenal leader in IPC, and she delivered our prestigious Cockerell lecture. And the title of her lecture was around resilience. And one of her first statements was highlighting that it's really encouraging from some of the other sessions that we've seen that actually resilience is now part of national incident responses, which is really, really positive. However, she suggests that maybe we are focusing too much on personal resilience, and what we need to do is shift to that system leader thinking, which concurred with Sam Machin's talk. And Tracy makes it really clear that resilience is not just about bouncing back, but it's about building strength. And I just love that. But to be able to do that, we've got to be looking after ourselves. And she signposts to sort of Mental Health Foundation. There were 7 steps to protect from stress, which basically encourages us to do what makes us happy. And the idea of that is it's essential for our energy and refocus. So she also talks about resilience, including having the right resources. So it's about your EPI, your data surveillance, perhaps. And she talks a bit about having this surge capacity and having these surge capacity models. And she gave a really great example where bank staff have been utilised very successfully for surge capacity. So these bank staff had received additional training, so they could be deployed and manage those surge demands. So Tracy, in a very inspirational manner, she provides us with some key lessons, recognising that the goodwill to deliver services has pretty much been shot by COVID. The key to team resilience was really about having emotional intelligence. And when we look at the emotional intelligence that she presented to us, it's about the self-awareness, the self-regulation, motivation, empathy, social skills. And what I encourage us all to do is just reflect on actually how well we perform on those emotional intelligence indicators. I certainly need to think about how I perhaps do things and how I should do things a little bit differently. She also signposted to lots of West work around the King's Fund. There was a particular document called Caring for Change. I really encourage you to read that. And of course, the importance of compassion, being able to walk in others' shoes and being able to exert that influence on the thoughts and actions of others. So she ends with the Cooper model, and maybe John, Phil, we can put this on your website if she agrees. It was brilliant, just a fabulous infographic on the core requirements that she's put together herself from years and years of experience. And I just want to end with a really strong message that she said at the end. And I've actually used it today in my work today. She said, to build a strong team, this is what you need to do. You need to put an umbrella up for your team so you can defend them. And I just think that is so powerful. So they are the sessions that I wanted to highlight. Thank you.
Okay, thanks, Jude. That's great. So we'll take questions now before we hand over to Mark for his individual highlights. So do please put anything that's on your mind in the Q&A box. But Jude, I mean, first of all, congratulations. We are in the presence of the new IPS president. I was wondering if we could find some kind of crown or tiara to put on you virtually, but I couldn't work out a way to do it.
They took my little gong thing away from me, so I couldn't even put it on today. So
well, you don't even get to keep it. I mean, what's the point? So I really liked how you described that, and I think something Tracy said right at the start, which you amplified, was part of the secret of having a resilient team is not being resilient in the way that we often define it, which is just keep going and keep saying yes and keep taking on more and have a stiff upper lip and keep going, because that's actually the way to break yourself and a team. So being resilient is about being structured and strategic and saying no to the right things and yes to the right things, so that we can have an infrastructure where everybody has capability. Otherwise, it becomes a network of favors and goodwill runs out.
Absolutely.
It's nice to hear you so full of energy, Jude, and you know, using that quote straight away. You know, there's no time like the present, is there? It's really interesting, you know, that perspective around resilience, and you know, using the umbrella as well, I think is key, isn't it? And I think that's a job that we have as leaders, but definitely can relate to, you know, the impact of COVID and how that took a lot of that away, and now it's about rebuilding it.
Absolutely.
So work as intended versus work as done. The thing that sprung to my mind was policies, and that feels like a classic case of work as intended versus work as done. I always get it the wrong way around as to which is what happens in the real world and what happens on paper. But that's such a classic case, isn't it? We can write these brilliant long policies, and yet nobody ever reads them and just does what they want to do anyway. But my question was really, how can we make that concept a bit more practical? You mentioned some kind of tool, and how does that help us to make it live?
I think it kind of gave you a process. What she talked about is breaking down the process. So as a linear concept, sorry, and to make it as simple as you can. And if you break it down, you can then build it back up, but get the people that are doing it part of that. So you're not writing a policy or a guideline without really understanding what actually goes off in real life, because actually we need to incorporate that so actually people can do the right thing. And sometimes at the moment, things are put in place and it's not easy for people to do the right thing. And that's why we get near misses and mistakes might happen. So yeah, her trick was really about just breaking it back down to simplicity, and then using, you know, the people that are going to be using it to help you sort of build it back up again.
Yeah, so I suppose I'm thinking stakeholder groups and listening to feedback and making sure that you use those people to attach you to reality.
Yeah, absolutely.
Okay, well, look, thank you, Jude. Please fire in any questions as they come to your mind, but we're going to hand over to Mark now to hear your highlights from the conference.
Thank you both for inviting me. So yeah, mine's going to be quite sciencey. And I'm going to start off with basically Jack Gilbert. So he's, I don't know if anyone has ever seen he's got a few TV programs actually all on the microbiome. Anyway, he's a professor over in America, originally from like the UK, spent a bit of time over in America and back and forth. Anyway, he works over in the University of California, San Diego, and he was our ALIF lecturer, and his talk was on the precision microbiome medicine. I've always been fascinated by the microbiome anyway, and I think it's just, people know my views anyway from an infection control point of view, how I think the environment plays a big part in the transmission of organisms. And it was fascinating how he showed that video at the very beginning about how our microbiome can transmit into our surroundings and to other people. You know, we've got like 100 trillion microorganisms on us that he alluded to, and even you think there's 100 billion galaxies, it's a lot. And the video he showed of us expelling 50 million microorganisms into the environment was fascinating, and just shows the importance of the environment. He also showed very nicely through a paper that was he quoted in Science Translational Medicine, I think by Laxatel, how staph also can be vectors of transmission via the hands and the environment as well. And then he went on into just detail about how some of the work that he was doing. I was quite envious of the amount of like grants that he had, a £200 million grant here and another £200 million grant there, but how he was working with Richard Beckett's down in London, looking at using biological active materials such as bacillus on the floors that can degrade bacteria, thinking of different methods that you can use from a cleaning point of view. And I know, Phil, you're probably going to go into your reflections talking a little bit about cleaning. I'll then just give you an overview of the microbiome, of how it can probably change like the medicine that we deliver. You know, it's fascinating when he was looking at like surgery and how you know, when you repair like the gut wall, and he showed some work in mice models that if you like, if they have a preponderance of like enterococci in the gut and they can break down the collagen, that can degrade your surgical wound and lead to infection that way. So it just goes to show how your microbiome has a massive role to play. If you think of like the environment that we deal with, lots of antimicrobials, disrupting that and how bacteria can affect that. It was quite fascinating. So that was one of the take-home messages for me from that I quite enjoyed. The second one was one of my best friends at university. That was Mark Webber. He's a professor over in Norwich, East Anglia University now, and he gave a talk on biocides. And I think I quite liked his talk around biocides and how we should have like some more guidance on how we should use biocides, and he looked quite a bit around resistances within the biocides, and it was he showed on one slide, fascinating how you can get resistance when you look at like antimicrobials, can very, very easily get resistance to those, but then when you look at some of the biocides, it's very difficult to get resistance into that. I loved how he went on and showed around how like his work around biofilms within that, and how they can, when they get exposed to biocides, how they can it affects their biofilm ability to produce biofilm. And if you think about that, you know, that's quite understandable from that. So I really enjoyed his talk on that. And finally, probably the other talks I really liked was on the final day, was Professor Alan McNally, a bit biased here, but he showed or presented all the CPE data, the carbapenemase producing Enterobacterales data at UHB. Although it wasn't, we've seen it in certain other hospitals. I know you have down in London, John, but it was fascinating how we've basically had a plasmid that's got into our hospital and it's evolved, and that's quite scary when you look at it, and just shows you, goes back to Jack's talk, really how bacteria can evolve during time, and how we've got a plasmid mediated transmission of this one plasmid that's evolving through time. And it's quite scary how these bugs work and share share their genes. And the one specific one that he was talking about, how it's developed like an insertion sequence, and it can suck in other resistance genes, like arsenic and mercury resistance, just shows that there's some kind of role from the environment from that. I really loved how they showed the role of genomics as well, how we can use that in our clinical practice, what's quite tricky. And then I think finally, summing it all up, I quite like Martin Kiernan when he asked a question in the one lecture of those, talking about the hospital, and I think we had like a completely water stream, and how the water system is like a gut of microbiome that we have to deal with, the wastewater system. So those are probably my highlights from conference. I think I've done that in 5 minutes.
Thanks, Mark. Really interesting. I agree with you about Mark Webber's work, and I think he paid a lot of tribute to the people who work in his lab, just the sheer amount of data that they produced, and all the different combinations of, if you test these organisms against these biocides, what does that mean to their resistance to these antibiotics, and this idea of cross resistance. I just wanted to pick up what you were saying about biofilms, because I think that Mark talked a lot about the work that they've done around biofilms, and this idea of tolerance and resistance to disinfectants, and the need for more definitions. Do you think that's something that people, when they're using disinfectants in practice, they think about, this idea of resistance to biocides? And do people understand what the difference between resistance and tolerance is? What do you think?
No, I don't think they were. I think it was a fascinating slide that he showed of like how you get tolerance, and like, similar to antimicrobials, where you have a minimum inhibitory concentration, so it inhibits like a certain amount of the growth of the organism, and then the bactericidal, where it actually kills everything. And I don't think people would know that. I know that from all the bits of like my PhD and what have you. So I don't think people would know that. And I found it fascinating how certain biocides, the bactericidal concentration for that was so much lower. But then when you looked at like meropenem, for example, our carbapenems, the generation of resistance and so forth it's quite different. And I think last year's conference as well, it was quite good when we had a talk around like biocides again. I think the more understanding of that will help people how to use them in clinical practice. Okay, Mark he was talking about one specific bug in a biofilm, and when you're talking about like a natural biofilm and things like that, it's quite different, and they exist for long periods, don't they? You'll never really get rid of them, but I do think there is a bit more understanding needed.
Can I just throw in a question, Mark? It was actually one that the chap who spoke about CP genomics asked, and we didn't really get to the answer. So this idea of routine sequencing of pathogen sets, rather than kind of a kind of in-out outbreak mode, whole genome sequencing. Do you think that idea has a future, that we just have a background churn of whole genome sequencing? And why would you do that rather than just doing it from time to time?
Yeah, I think it's better to have an overview of what's going on with all the microorganisms. So he didn't really present some of the work that we've done, but and neither did Nicole Stozer, who was after him. So, for example, they've sequenced all of our E. coli bacteremias for a whole year, all of them, all the bacteremias. Okay, it's not every single isolate, but the data out of that is really, really interesting. So you have specific sequence type that have he's identified. I think there's about 5 or 6 different sequence types. And it's not what I expected. So there's common ones. They're not all antimicrobial resistance, and they're quite diverse. So it doesn't look like it's like a transmission event. I know people have E. coli, but that will enable me to think of different interventions. So, okay, it's not like a transmission event. So what can I do? Can I think of certain other things to influence my practice to try and reduce those down, go into the community, look at like, UTIs, biliary sepsis, that kind of stuff. So that's really quite interesting data. When you looked at the CPEs he gave, the QE where I work is very different to to the other hospitals, and you can see there's transmission events in there. So when I presented a bit in the lectures that I gave, some of the interventions I put in place, but that's only on the back of the sequencing. So you can tailor make it. He talked a little bit about the MDM outbreak that we had over at one of our sites, and okay, that's a real life outbreak point of view, but the interventions, understanding it fully, you were able to put slightly different interventions that I would not normally do due to the data. So I think it'll just give you more powerful, richer data to understand that microorganisms to put your interventions in, because with like the gram-negative reductions that we're meant to do, people are saying, well, what interventions can we do to reduce it down? And you just basically, in infection control, when you have an outbreak, you tend to chuck the kitchen sink at it, don't you? So I think it just needs to be, your hospital will be very different to mine from the different epidemiology that we get. So I think that will just give you a bit more understanding of like some of the interventions that we can put in place. I probably haven't explained it that well, but that's how I see it. Like the E. coli data was fascinating, and the Klebsiella bacteremia data was fascinating as well. It wasn't like all transmission. I was thinking, it's all associated with water, and it wasn't. So it was just certain things like that.
I think the concepts are there, aren't they? Maybe we need just a little bit more focus on evaluation outcomes and cost effectiveness, but to kind of overcome the perceived barriers. And why aren't we doing whole genome sequencing more? Mark, you've been very humble. You haven't mentioned your Bradley lecture, your guest lecture.
Yes, that was quite emotional to do that. Mine's very like, that was I can't believe Jude and the SPC persuaded me, but while in Birmingham, that was a pleasure to give that. Mine's quite practical though, compared to some of the other talks. So talking about the experience, I mainly try to show Tina's wisdom in that talk, how she influenced my career, and often the simple solutions are the easiest. And I do think, although I'm biased, of like how a multidisciplinary team with like science and putting that science behind some of the stuff that we do can really help.
For those of you who don't know, Tina Bradley was a scientist who worked very closely with Mark for many years, but actually all four of us knew her and worked with her from time to time. So she's greatly missed. Okay, thanks, Mark. So just a note in the chat from Victoria, thank you. A Netflix recommendation for this evening, Hack Your Health. Not something I've seen before, but I'll be searching it up later. Okay, Phil, I think we're over to you.
Thanks, John. I'm going to go a little bit left field to begin with and just comment on a lot of the feedback that there was around the programme and kind of congratulate the SPC on putting together a wonderful programme. I think there was so many times where I myself just didn't know which talk to go to because there were 3 running in parallel and you had to make tough decisions. I think the quality of the feedback coming from delegates around how good the programme was really positive. So I think it was a great conference overall. I've kind of got themes with the things that I was talking about, and I think it's all around environmental decontamination, which is, one of my main interests. And there was some personal highlights for me because there was 2 young ladies who presented a little bit around challenges when it comes to environmental decontamination. Dr. Izzy Centeligi and then Lauren Brown, who I'd worked with really closely in a previous life. Izzy talked about biofilm, both wet and dry, and I was lucky to supervise Izzy when she did her PhD. She's now leading this massive consortium called COMBAT, which is multidisciplinary across home, hospital and farm, and looking at the role of antibiotic resistance within biofilms. So it's really great to see just how far Izzy's come, and she's just landed a really big postdoc job in Australia. So Izzy talked about the challenges of biofilms and how, dry biofilms is a phenomenon now that I think is becoming a lot more commonplace in infection control, talking about just how widespread they are and how difficult they are to eradicate. And I really liked what Izzy was talking about how potentially we need to think differently when we think about decontaminating the environment. Because if these biofilms are there, they can survive and persist for long periods of time, but does it actually mean that there's a higher propensity to move them around and transfer them over to other surfaces? And if we do manage to get their numbers down, how quickly do they regrow? So thinking about, we've got all these standards available to us when it comes to disinfectant testing, but do we need to think a little bit more differently, sorry, about how we use our disinfectants and how we assess their activity. And then just after Izzy, Lauren, who is a scientist working in the private sector, she talked about the challenges around using 2-in-1 and whether or not you can clean and disinfect in one step. And I thought Lauren used some really good what I would call traditional lab data to show some of the challenges there are when it comes to cleaning and disinfection, and whether or not you can do them in 2 steps. And she also talked about the challenges with chlorine, and how chlorine doesn't tend to perform that well in the presence of dirt. So I think that Izzy and Lauren's sessions highlighted for me, some of the challenges there are around environmental decontamination. And I want to link that really quickly to one of Mark's slides in the Tina Bradley lecture, where Mark talked about the ready available concentrations of chlorine being used in practice. And I think those results that Mark presented were just so stark. We're talking about looking at the concentration of available chlorine being used at the Queen Elizabeth Hospital, and just how much variance there was. People were using as low as, I think it was 40 or 50 parts per million chlorine, and the recommendation is 1,000 parts per million. And then in other cases, it was well over, and it was into the thousands of ppm. So I think just having that insight into what's really going on in practice, and we've got these recommendations about what we should use and what concentration we should use. You've got Izzy and Lauren talking about the challenges, and then Mark showing about what's actually happening in practice. And it just seems to be, a really difficult challenge in order to get people to do things correctly, to try and overcome some of those challenges. So I thought that was kind of a nice link in. But then I want to link it back to the work that Brett Mitchell presented. So Brett presented the CLEAN study, and I think we're just all in awe of Brett's ability to present, but also just the amount of data that he's generated in this study. I think for me, when I thought about the CLEAN study, I was really interested to see what the impact was on infection rates. So for those of you, listening for the first time and haven't heard about the CLEAN study basically was increasing the amount of time spent by domestic or environmental services staff for cleaning shared medical equipment. They did an extra 3 hours every week. And that extra 3 hours resulted in around about a 35% reduction in healthcare associated infections. So, I mean, it's already a really important headline, but for me, it's all the other work that's gone with it. So I really like the work that he presented about showing how long it takes to clean shared medical equipment. They've been through and done this really pragmatic study saying, well, if you're going to clean this equipment effectively, how long does it take? And, how often should this equipment be cleaned between patients? It probably needs to be cleaned 4 or 5 times a day. So, Brett used this really nice bit of data where if you clean a commode properly, it takes 5 minutes. If that's got to be cleaned 5 times a day, you're expecting that nurse to spend 30 minutes of their shift cleaning a commode. And, is that actually feasible given that all the other things that our nurses have to do? So I think, that really highlighted the challenges there are, but actually by improving and increasing the amount of cleaning, we showed that it make a difference. And I think the final thing for me just to say on the CLEAN study was Brett talking about the cost effectiveness, and that actually, the CLEAN study was a lot more than just cost neutral. There was a lot of cost savings involved, because we know that if we can prevent these infections happening, we can reduce patients' length of stay, we can reduce treatment costs. So I think that Brett just presented this wonderful package of data, right from a really high-powered randomized controlled trial showing you that reducing infections is possible by improving your cleaning, but then also these other considerations that we need to make about, do we give our staff the right amount of time? And I thought, linking Brett's work to the work that Izzy and Lauren had shown about the challenges just shows that if we do things and give them a bit more time, that we can make a difference. So it's not, I often think that the environment and the environmental decontamination feels like there's so many challenges. But actually, I think what Brett's study showed that if we can just give more time and resource, And something that I'm really passionate about is empowering our cleaning staff, because they play such a vital role in keeping the environment safe, that if we can actually put more resource, give them more time, and really make it a science-based profession, which I think it is, then it can really make a difference on patient safety and patient outcomes. And that's me.
Yeah, okay, great, Phil. I mean, just picking up on Sally's comment in the chat from earlier, and spending time walking in the shoes of our colleagues before we start making guidance and recommendations. I mean, that couldn't be more relevant for cleaning and disinfection. And I think some of the outcomes of the clean study around just the time that it takes to clean things properly, it is very underestimated. But I mean, to solve that requires some new resource in the system, isn't it? Because if we're saying you need to clean properly, you need to spend half an hour cleaning commodes every day, who's going to do the half an hour of whatever else they would be doing? It needs some more financial investment in the system. So how do we make the case for that?
It's something I've heard before, but I really like this idea of having somebody whose job it is to go and clean shared medical equipment. So they are either a specialist cleaner and they're focusing on high risk items. Because I think you presented some of the work, John, that was done out of Cardiff, and Professor Jean-Yves Maillard's group, talking about there's so much variation in policy when it comes to cleaning shared medical equipment. People do it, they use different agents, there's different responsibilities. And so I think that it's already really difficult to try and highlight whose responsibility it is. We know cleaning is everybody's responsibility, but I think, sometimes it can be a bit tricky. We've all got time constraints and there are challenges. So I really like this idea of potentially trying to create a role within an organization where there is just a real focus on cleaning shared medical equipment. And I think that you could put some really nice requirements into that role to make it really specialist, really focused, and then potentially really make a difference.
I think there's something there, though, about how we value our facilities and cleaning staff. Like, when do cleaners ever, or facility staff, domestics, whatever you choose to call them, when do we ever say, the job you did today, that saved lives? When do we ever do that? And I think that is that whole culture change as well, and on just how vital and critical they are within our health and social care systems.
Yeah, I completely agree. I spoke at the AHCP day, which they ran jointly in Wales with the IPS back in the summer. And, I think that there was a lot of energy in the room when you talk about the importance of that role. And let's be honest, they're not very well paid. There's often a high turnover of staff. There's language barriers. So I do think there's a role for infection prevention and control to play, to really empower that role and really demonstrate to our organisations about how important it is.
I mean, I know this is a bit like throwing a starfish back into the sea from the beach full of starfish, but when I'm out in the hospitals, I do try and single out the staff doing cleaning, whether that's full-time cleaners or other staff doing cleaning. But I guess the question is bigger than that, isn't it? All of us doing that isn't going to solve it. It needs to be a bit of a culture change and a culture shift. And I think some of these outcomes around real impact of environmental interventions will help to raise the profile of that prevention work over time. Okay, so I'm really keen that we get some questions in from those who've joined us today. So please do fire some stuff into the Q&A. Question from Sally, really, or comment really. Cleaning is not made a significant issue in induction, and I suppose that's true of all staff groups, isn't it? Medical staff, nursing staff, who are all kinds of other staff. It's not something we include maybe in our core principles and training and initiation into the organisation that we should. It's a really good point. Okay, let me just share then 2 quick highlights from me, conscious of the time. I went to a great talk by Giovanni Battista Fucini, and apologies for any mispronunciation of the name, around the idea of going water-free care. I'd actually read his paper, which is great. It's an epidemiological study, and it shows that patients who were cared for intensive care units in Germany that had a sink within the bay or the room had a higher rate of healthcare associated infection than those who were cared for in a room that didn't have a sink in, which has some far-reaching implications. It's a good study because it's focused on healthcare-associated infection as an outcome, so really impactful events rather than the acquisition of MDROs, which other studies looking at sinks have focused on. And the rest of the talk, he really talked about the practicalities of going water-free, the kind of work you need to do to go through the different systems and approaches that you would need to take to actually make the jump to go water-free. I'm interested in how we can leverage the data that's there now to practically make steps to going water-free. And that's convincing the hospital board that it's safe and it's good and it's right. It's convincing the IPC team, all of whom may not be on board with the concept and the data. And I mean, it's probably most importantly, it's walking in the shoes of the frontline teams and thinking, well, what are the alternatives here, and what changes in practice do we need to make those real? And just very quickly, lovely talk by Silke Schellens from King's around the emergence of Candida auris and her experience of the first outbreak in Europe, which was at the Royal Brompton, which is now one of my hospitals in the group. So that resonated with me. It's a really challenging organism for reasons we don't understand. This resistant fungus is spreading across the US in particular, and we're seeing more and more outbreaks in the UK. In talking with her afterwards, it seems like almost a good marker of bad practice, in that it seems really sticky. It seems to spread really easily, much more easily than other fungi. So if you can prevent the spread of Candida auris, that's a sign that you can prevent the spread of other things too. And the final thing that she mentioned that made sense to me was they were able to really focus on good line care of vascular lines in order to prevent colonization transitioning into infection. And through a multifaceted bundle aimed at improving line care, they were able to stop those transitions from colonization to infection. And I think that concept is really transferable to the other, especially antibiotic-resistant bacteria we talk about, so CPEs. We may not be able to prevent every transmission event, but we can certainly do a better job of preventing that transition from colonization through to infection.
Thanks, John. Great insight. Just one quick question, because we have got a question for Mark, which we'll go on to slightly shortly. But this concept of water-free, I think, is gathering a lot of momentum. But do you think it should be water-free, or do you think it should be water-light? Because the ability to completely remove water is obviously quite difficult, and it's always going to be required in some setting or some elements of care. So do you think it should be water-free or water-light?
So I suppose we're made predominantly of water, aren't we? So if we want to have water-free healthcare, it doesn't have any human beings in it. So yeah, I think you're right. It's misbadged and it's misbranded. Maybe water-light. Maybe we could talk about sink water-free or maybe tap water-free, because I think it's the sink water and the taps that are the real challenge here, and the drains. But perhaps a rebrand would be helpful.
It's really interesting, John, that you've said that, because me and a colleague went to see an organisation a couple of weeks ago to look at kind of how they'd done this water-light, water-free stuff. And our observations was actually they've gone sink light rather than water light, because they've got these great, warming units that stores, sterile water for all of their procedures, whether it's wound care, mouth care, whatever you need it, washing, patients, etc. And it's brilliant, absolutely brilliant. And what they've done is take what is the problem, which are the drains that are causing the issues and the splash risks and all that. So yeah, they'd actually gone sink light. And I think when we're trying to talk to boards and get execs on board, they're going to freak out when you say, right, we want to take all the water away. However, they might get on board with it if you go, actually, I just want to take some sinks out and we're going to replace it with something that's less dangerous for our patients.
Yeah, Mark, sorry, Phil. Mark, I was just going to say, have you gone water-free or water-light in any parts of your hospitals?
No, it's something I want to look at. We've got like it's quite interesting when you look at the new PF, like the PFI. I say it's not a new PFI now. The QE, the amount of like water outlets that we've got on our ITU is about. We've got 230 odd outlets on ITU. What makes it, it's just too many. I don't really think like a waterless is achievable, as Phil's alluded to. I think water light, using less water, whatever you want to call it, is probably the way forward. I do think the more I look at it, I think I know you mentioned it last year in your top 10 papers in your final comment, didn't you, John? Like, the more you think about it, water is a massive vehicle. And like Martin, like I said in my top tips at the beginning, I think the wastewater has a massive role to play, and I don't think we look at it enough, really. So it is something I'd like to do. I think, you know, when you look at like the designs of sinks and taps as well, that's quite tricky. You know, they talk about shark fin sinks. Shark fin sinks will eliminate the spray, but if you don't get it right over the shark fin, I think it's quite tricky. I had like a lot of reviewers come back to that waterless free commentary that I was asked to be quite biased about having a waterless. It was quite interesting, the comments that came back saying how you can adapt, you know, your taps and sinks and things like that, and really target that. The answer is no, John, but it is something I'd like to do. I think it's a combination of a lot of different things and understanding the risks of the wastewater, and also it's always an age-old debate of like, people ask of like how you'd ever decontaminate. You're always gonna have biofilm, you see, aren't you, because of like the Pseudomonas in your water and the bugs that you know. So it's you know, the wastewater traps is how that will be a massive like source of like antimicrobial resistance. It's interesting as well, when I've like tried to do environmental sampling, the only time I've ever found like CPs or like resistance is down like your IV drug rooms, basically, because really all the drugs go down the sink. So I know Nicole mentioned that as well. So I do think we need to look at it, but no one's ever given any practical advice of doing it, have they, really?
Thanks, Mark. I've got one question for each of the panel. So if we can keep it short, what would you like to see on the programme for IP 2025? Maybe a theme? Jude, any thoughts?
I think I might need a minute. I think
Okay.
There's a lot around. What I loved about the last few sessions, for those that didn't make it to the bitter end, there was a lot around kindness, psychological safety, and I think we've got such a way to go to get that right. So I think I would probably like a real emphasis on that. So Claire did just such an empowering session around bullying and harassment, and really just shone the light on, actually, we cannot accept this. It goes on all the time, and people ignore it, and actually we've got to not be a bystander but be an upstander. And you know, that really stayed with me, so I'd love to see more of that on the programme for IP 2025.
Victoria suggested practical guidance on pandemic planning. Very good suggestion. But just quickly for me, everything we've talked about today, it depends on there being really committed and effective research leaders in our community. And I think we need to think about the next generation and how we're going to support people to develop those research skills and give them opportunities to produce the kind of data that we're so excited about today.
Yeah, couldn't agree more. Anything for you, Mark, you'd like to see next year?
Yeah, I'd probably like what we tried to do this year, but it didn't come off so well. It is having more a little bit more syndromic stuff. I know we have talked about it, like a target of the big hitters like HAP and HAP, VAP, things like that. So that we tried to do that in the one session, but it didn't come off this year as an SPC. I'd quite like that. I'd quite like to look at that like German model of where they reduce down hospital acquired pneumonia down. Is it Alice Wasenberger or something like that? I can't remember. That paper came out of Wolfsenberger. That's it, isn't it? Wolfsenberger. That was quite an interesting model. I'd quite like to see her present. I'd like a little bit more on. So we had quite a bit on water, but it was quite samey. well, I say quite samey. They're really good talks, but they're a little bit more samey. I'd quite like a proper like well, this is not out, a proper like RCT of a waterless ITU. That would really be, I don't know how you do that, but I'd quite like something like that. But yeah, that's probably me.
Thanks, Mark. Lots of comments in the chat as well about infection control in community and mental health as well, which is great feedback, and we'll bear that in mind for conference next year. Okay, John, over to you.
Okay, well, look, thanks everybody for joining today. Slightly different format. I hope it worked for you. We're always welcome to your feedback. Next week, we'll have our next journal club. It'll be Phil leading on biofilms, implications for cleaning and disinfection. The registration information is all on the IPC Partners website. And just a reminder that this journal club is hosted by IPC Partners. And thank you for coming, and hope to see you next time.